Neoplasms of the skin include both benign and premalignant lesions. Seborrheic keratosis is a very common skin tumor in people older than 50 years of age with an unknown etiology. Although the lesions may look similar to melanoma, they have no malignant potential. They present as exophytic, waxy, brown papules and velvety or greasy plaques with superficial keratin cysts. Lesions often appear in large numbers and have a characteristic stuck-on appearance. They can become irritated either spontaneously or from external friction trauma. Diagnosis is clinical, but biopsy may be done to rule out malignancy. A key fact to remember is the lesser Tralat sign, which refers to the sudden appearance of multiple seborrheic keratoses in a Christmas tree pattern on the back and is associated with internal malignancy, most commonly gastric adenocarcinoma. Treatment options include cryotherapy, shave excision, or curettage. Actinic keratosis presents as flat areas of erythema and scale caused by chronic sun exposure, especially in fair-skinned individuals. These lesions carry a 5% to 10% risk of progressing into squamous cell carcinoma, so treatment is necessary before malignant transformation. Lesions typically appear on sun-exposed areas, such as the face and arms, and primarily affect older patients. They appear erythematous with a sandpaper-like texture and may become thick and crusted over time. Diagnosis is clinical, though biopsy may be done to differentiate from squamous cell carcinoma. Treatment options include cryosurgery, topical 5-fluorouracil, 5-FU, or topical imiquimod, all of which destroy the lesion. Patients must also be advised on strict sun protection to reduce recurrence and future risk. Cutaneous squamous cell carcinoma, SCC, is the second most common skin cancer, with both locally destructive effects and the potential for metastasis and death. Sun exposure is the most common causative factor, but additional risks include exposure to chemical carcinogens, prior radiation therapy, chronic inflammation and chronic wounds such as burns or draining infectious sinuses in osteomyelitis, and chronic immunosuppression such as in transplant recipients. Keratoacanthomas are considered a low-grade type of SCC. SCCs have many forms, and a single patient may present with multiple variants. Most SCCs occur in older adults with sun-damaged skin, usually arising from actinic keratosis and present as erythematous, ulcerated papules, or nodule. Most lesions are exophytic nodules with erosion or ulceration, and some may show crusting. Neurologic symptoms can occur due to perineural invasion. A marginal ulcer is a rare type of SCC that develops in sites of scars, burns, or ulcers, typically taking 5 to 10 years to appear after the initial wound. Another rare cause is arsenic exposure, which can result in multiple SCCs in a palmoplantar distribution. SCC in situ is referred to as Bowen disease and presents as a well-defined erythematous scaly plaque, whereas when it occurs on the penis, it is called erythroplasia of Queyrat and appears as red, velvet-like plaques. SCCs arising from actinic keratosis rarely metastasize, but those developing on the lips or in ulcers are more likely to spread. SCC occurs on the lower lip more commonly than basal cell carcinoma. Diagnosis is usually based on characteristic clinical findings and history, with confirmation by shave biopsy, which typically demonstrates keratin pearls and full-thickness atypical keratinocytes with invasion into the dermis. Treatment involves surgical excision or Mohs micrographic surgery, in which very thin slices are excised and immediately examined under a microscope using frozen sections, making it ideal for cosmetically sensitive areas such as the face and distal extremities. Lesions with high metastatic potential may also require radiation therapy or chemotherapy. Basal cell carcinoma, BCC, is the most common malignant skin cancer. It is slow-growing and locally destructive, but has virtually no metastatic potential. The primary risk factor is cumulative sun exposure, and most lesions occur on the face in fair-skinned individuals. The presence of multiple BCCs that appear early in life and in non-sun exposed areas suggests inherited basal cell nevus syndrome, also known as Gorlin syndrome. The nodular subtype makes up about 80% of cases, while other types include superficial and sclerosing. BCC typically presents as a pearly white, translucent, dome-shaped nodule or papule that may ulcerate, bleed, or crust in the center, often with overlying telangiectasias. Diagnosis is confirmed with a shave biopsy, which shows nests of basophilic cells invading into the dermis. Treatment options include excision by curettage, cautery, cryotherapy, and superficial radiation, with most micrographic surgery preferred for cosmetically sensitive areas. A useful mnemonic for evaluating suspicious pigmented lesions is the ABCDS of melanoma: asymmetry, border irregularity, color variation, diameter greater than 6 millimeters, and evolution of a changing or new lesion. Melanoma is the most common life-threatening dermatologic disease. Risk factors include fair skin, a tendency to burn, intense bursts of sun exposure, especially during childhood and with intermittent exposure, and the presence of large congenital melanocytic nevi, an increased number of nevi, or dysplastic nevi. Immunosuppression also increases the risk. Some patients inherit a genetic predisposition to melanoma, as seen in familial atypical mole and melanoma (FEMM) syndrome. Melanoma has several subtypes. Superficial spreading melanoma accounts for about 60% of all cases. Its incidence increases with age, but it is also seen in young adults. It often presents on the trunk in men and on the legs in women. This type has a prolonged horizontal growth phase, which allows for early diagnosis while the tumor is still confined to the epidermis. Nodular melanoma grows rapidly in a vertical phase and appears as a fast-growing reddish-brown nodule with ulceration. Acral lentiginous melanoma begins on the palms, soles, or nail beds as a slowly spreading pigmented patch. It is most common in Asian and Black populations. Lentigo maligna melanoma arises within a solar lentigo and is usually found on sun-damaged skin of the face. Amyloidotic melanoma presents as a lesion without visible pigmentation, making it more difficult to identify, and this variant can be classified into any of the above types. History and physical examination, P. Malignant melanomas originate in the basal layer of the epidermis, where melanocytes reside. These tumors are highly aggressive and can metastasize to virtually any organ in the body, including the lungs, liver, brain, and even fat. Interestingly, in about 3% to 5% of patients with metastatic melanoma, no identifiable primary lesion can be found. Diagnosis. Early detection is crucial because melanoma is potentially curable when recognized in its initial stages. Screening exams that apply the ABCD criteria and the use of dermoscopy are valuable tools for identifying suspicious lesions early. Any lesion that appears concerning should undergo an excisional biopsy, which allows for histologic confirmation of malignancy. A particularly important diagnostic clue is the ugly duckling sign, a mole that looks significantly different from surrounding moles. This sign has greater than 90% sensitivity for detecting melanoma. Melanomas are staged using Breslow thickness, which measures the depth of tumor invasion in millimeters, and the tumor node metastasis (TNM) system. The presence of ulceration is considered a poor prognostic indicator. Treatment. For melanomas confined to the skin, The mainstay of therapy is surgical excision with appropriate margins. A sentinel lymph node biopsy can be performed for staging purposes, though it does not improve overall survival. For cases of recurrent or metastatic disease, additional modalities such as chemotherapy, biologic therapy, and radiation therapy may be used. Patients diagnosed with early-stage melanoma typically have a low risk of recurrence, but carry a high risk for developing new melanomas in the future. Those with more advanced melanoma are at higher risk of both recurrence and metastasis. For this reason, ongoing patient surveillance is essential to monitor for progression, recurrence, or the appearance of new lesions. Clinical case. A 72-year-old man presents to an internist after moving to Florida. The internist notes a chronic wound on the patient's right lower leg in the area of a previous flame burn. The patient states that the wound has been present for 5 years and has not healed despite receiving dressings and topical treatment. What is the next best step? The next best step will be to perform a biopsy to rule out SCC. Kaposi sarcoma. Kaposi sarcoma is a vascular proliferative disease that has been attributed to human herpes virus 8, ch8, also called Kaposi sarcoma, associated herpes virus, KSHV. It presents with multiple red to violaceous macules, papules, or nodules that may progress to plaques on the lower limbs, back, face, mouth, and genitalia. These plaques may also be found in the gastrointestinal tract and lungs. HIV-associated, also called epidemic Kaposi sarcoma, is an aggressive form of the disease, and although it has become less common since the advent of highly active antiretroviral therapy, HAART, it still remains the most common HIV-associated malignancy. The diagnosis is made by history, clinical impression, and histology. Treatment begins with initiation of HAART if the patient is HIV positive. Small, localized lesions can be managed with radiation therapy or cryotherapy, while widespread or internal disease requires systemic chemotherapy such as doxorubicin, paclitaxel, or interferon alpha. A key fact to remember is that bacillary angiomatosis, caused by Bartonella henseli or Bartonella quintana, can mimic Kaposi sarcoma. This condition must be excluded in suspected cases, and erythromycin is the treatment of choice for bacillary angiomatosis. Mycosis fungoides, cutaneous T-cell lymphoma. Mycosis fungoides is not a fungal infection, but a slow, progressive neoplastic proliferation of epidermotropic T cells. It is a chronic disease, more common in men. Early lesions are nonspecific and appear as psoriatic-like plaques or patches that are often pruritic and tend to occur on the trunk and buttocks. As the disease progresses, later lesions may develop into skin tumors with palpable lymph nodes. Patients may show dermatopathic lymphadenopathy without tumor involvement of the node, but internal organs such as the lymph nodes, liver, and spleen may eventually be involved. The leukemic phase of cutaneous T-cell lymphoma is called Sézary syndrome, which is characterized by circulating Sézary cells in the peripheral blood, erythroderma, and lymphadenopathy. The diagnosis of mycosis fungoides is based on clinical features and histology, with immunophenotypic studies demonstrating clonal T cells and electron microscopy showing the characteristic Sézary or Lutzner cells, which are cerebriform lymphocytes. Because early lesions are clinically indistinguishable from dermatitis, any chronic dermatitis resistant to treatment should undergo histologic examination. Treatment consists of phototherapy and skin-directed topical therapies as the mainstay. Early localized disease may be treated with total skin electron beam irradiation. For more extensive or advanced disease, radiation therapy is effective. In many cases, treatment modalities such as steroids, chemotherapy, retinoids, monoclonal antibodies, and interferon alpha are combined for optimal management. Cherry angiomas, hemangiomas. Cherry angiomas are small, vascular, red papules that can appear anywhere on the body. They're the most common benign vascular tumor and often develop with age. No treatment is necessary, but lesions may be excised if desired for cosmetic purposes. Infantile hemangiomas, also called strawberry hemangiomas. Infantile hemangiomas are similar to cherry angiomas, but are seen in infants during the first few weeks of life. These benign lesions usually undergo spontaneous regression after an initial rapid growth phase, with involution typically beginning around 9 months to 1 year of age. If persistent, they can be treated with topical or oral beta blockers. Pyogenic granuloma. Pyogenic granuloma is a lobulated capillary hemangioma that most commonly occurs on the fingers, trunk, and oral mucosa in young adults. It frequently ulcerates and bleeds profusely. The condition is often associated with trauma or pregnancy, likely due to increased levels of vascular endothelial growth factor during pregnancy. Treatment options include surgical excision, laser therapy, or application of topical silver nitrate. Importantly, lesions arising during pregnancy may regress spontaneously in the postpartum period. Necrobiosis lipoidica. Necrobiosis lipoidica presents as red-brown to yellow annular plaques that typically occur on the lower extremities, especially the pretibial skin of patients with diabetes mellitus. It is more common in women and presents as multifocal lesions with dilated blood vessels and central epidermal atrophy, which may ulcerate. Notably, necrobiosis lipoidica can precede the onset of diabetes, so patients presenting with this condition should be screened for diabetes mellitus.